And I'd like to introduce our second speaker, which is Alberto Giubilini, who's a senior research fellow at the Uehiro Center here at Oxford and also the Wellcome Center for Ethics and Humanities.
Thank you very much. Let's see if the slides work. Yes. Okay, so there has been some debate around how far healthcare professionals' duty can go, particularly during emergency situations, such as epidemics, before risks and burdens for their health become excessive and therefore beyond the call of duty. And there has been a separate independent debate about whether and when healthcare professionals should be allowed to conscientiously object to taking on or to perform certain activities that conflict with their moral views, most notably abortion, for example. Now, for some reason, these two debates never really interacted or intersected, although some of the core issues that they raise seems to me to overlap. So here, what I want to try is to bridge them, to bring them together, to address what seems to me the overarching question that both of them try to address, which is, at what personal cost do healthcare professionals have a duty to care for patients? So that is, what should be considered in light of the scope of professional obligations over-demanding and therefore beyond the call of duty for healthcare professionals. Now, things like risk for one's illness, health, even life in one case, or things like moral distress, moral injury, as David was talking about, stress of conscience. These are all costs that might make the delivery of healthcare very demanding for healthcare professionals, and on some views, and in some cases, maybe too demanding. Now, a more specific question here is what type of personal burdens, personal costs justify the withholding of healthcare? Is it only risks for one's health or also moral objections? So my aim here is not so much to answer these questions, unfortunately, but to suggest that this will be a more fruitful way of framing the debate around conscientious objection in healthcare than the debates that are normally framed in terms of attention between freedom of conscience on one side and professional obligations on the other side. So I want really to leave aside the issue of freedom of conscience here, although I will talk quite a lot about it, but only to leave it aside. Now, if we want to emphasize the fact that healthcare professionals are expected to take on themselves larger burdens and risks than the rest of society, especially in emergencies, a good place to look at, I think, is the discussion of the limits of a duty of care during the HIV pandemic in the 80s and 90s of the last century. For example, the American Nursing Association back then stated that care should be delivered without prejudice, and it makes no allowance for the use of clients' personal attributes, socioeconomic or health status as grounds of discrimination. The American College of Physicians, in their manual, they stated that physicians and healthcare organizations are obligated to provide competent and humane care to all patients, regardless of their disease state. The denial of appropriate care to a class of patients for any reason, including disease state, is unethical. Now, the question about personal risks for healthcare workers was very much intertwined with the issue of discrimination of certain categories of people, most obviously gay men, because they were the ones more likely to get HIV. But although these principles were formulated in the context of the HIV epidemic, they are phrased in more general terms that seems applicable to other contexts. And indeed, the requirement that healthcare professionals take on themselves additional risks compared to the rest of the population, especially in emergency situations, returns very often in professional code of practice and the position statements. So for instance, in the aftermath of the 9/11, the American Medical Association adopted this social contract with humanity, in which they declare that they're committed to apply our knowledge and skills when needed, even if doing so may put us at risk. Now, it's interesting here that they mention the social contract. So the social contract on which these positions are based, as a theory, is central to many views about professional obligations. One view is that healthcare professionals, I should say, do have an obligation to take on significant additional risks during pandemics in virtue of the social contract between healthcare professionals and societies. So when it comes to healthcare profession, the social contract is the same one whereby society grants healthcare professionals monopoly rights over the provision of certain services in return for the provision of those services that society deems appropriate. Now, not everyone who does a job or gets paid for something or provides a service is a professional. So in the strict sense of the term, a professional is someone who has societal license to operate in a certain field on the basis of the social recognition of certain skills, for example, academic credentials. So as Rosamund Rhodes put it, because society has granted medicine a legal monopoly over the use of its knowledge, powers, privileges, and immunities, the profession and its members are required to provide treatment for everyone who needs it and who wants to avail themselves of the services. Now, this statement is very problematic. I will get back to it because it doesn't seem true, but for the purpose of this slide, let's leave it there. So the point here of the social contract is that while we all have general positive duties to aid others in certain circumstances, the social contract grounds the professional and monopoly status of healthcare providers generates special positive duties on healthcare professionals. Indeed, according to this paper by Clark in 2005, there are 3 factors that ground such special professional obligations. First, Clark says, since the ability to render aid is greater in the case of healthcare professionals, then the obligation to assist is also elevated, questionable. The second one is that by freely joining a profession designed to combat disease, one consents to some standard of risk. And the third one is by realizing that the profession has flourished due to the socially negotiated promises to be available in such times of duress. Now, the implications of the social contract are often codified in codes of professional conduct that professional organization provides to their members. Now, this is about the social contract and the burdens and the risks that healthcare professionals should or might be expected to take on themselves. Now, let's talk a bit about conscience. So, to repeat, the American College of Physicians, in their manual, in the context of HIV epidemic, said this. So the denial of appropriate care, this is the same quote as I used before, the denial of appropriate care to a class of patients for any reason, including disease state, is unethical. So this can be seen as deriving from the social contract. Interestingly, in the same documents, just in the next page of the document, the American College of Physicians also say that the ethical duty to disclose relevant information about human reproduction to the patient may conflict with the physician's personal moral standards on abortion, sterilization, or contraception. A physician who objects to these services need not become involved, whether by offering advice to the patient or by involvement in the procedure. So this seems to suggest that it's not the case that denial of appropriate care to a class of patients for any reason is unethical, as for the first statement, since reasons of conscience here seems to be excluded. Now, there may seem to be a contradiction here in the statement. You might have identified some keywords here whereby you think there is no contradiction, and I will get to this. So I wanted you to examine this principle more closely to see whether the differential treatment of health risks and of conscience costs for healthcare professionals is justified, and therefore whether there is any inconsistency in this document. And the reason why I focus on this debate and this kind of principle is that it contains 2 crucial elements, which are often used with regard to the debates of conscientious objection, but that here are applied to the case of treating HIV patients. And these are discrimination and what counts as appropriate care. Now, the question is whether these 2 criteria provide reasons to treat the 2 types of burdens, like health risks and cost of conscience, differently when it comes to defining professional obligations. That is, maybe conscientious objection is not discriminatory in the way in which withholding healthcare from HIV-positive patients would be. So that might explain why there is this seeming inconsistency here. And maybe the things to which doctors or professionals object, most notably abortion, are not really appropriate care, or there is a widespread disagreement about whether they're appropriate care. Maybe there are these 2 crucial differences here. So, in fact, I would presume that a defender of conscientious objection will say that conscientious objection is really not discriminatory, unlike refusing to treat HIV-positive patients. And an opponent of conscientious objection in healthcare might disagree. So let's think about this issue of whether conscientious objection is discriminatory. So the claim that conscientious objection to providing abortion or other services is a form of discrimination is quite common among people who are opposed to a right of conscientious objection in healthcare. By the way, for full disclosure, I'm one of those people. I don't think I might be the only person in this room who think that there shouldn't be any right to conscientious objection in medicine. I think healthcare professionals should not have this kind of what they take to be a privilege. But, however, I think there are good and bad arguments for this position, and I don't think this is a good argument. So I don't think there is a problem with discrimination when it comes to conscientious objection. And I'm happy to debate about conscientious objection later, of course. So, for instance, in this paper by Fial and Arthur, they claim that conscientious objection to reproductive healthcare discriminates based on gender and pregnancy because reproductive healthcare is largely provided to women. Now, one might say that exactly as refusing to care for HIV patients could be or express discrimination against gay men, given that they are the ones more likely to get infected, so conscientious objection to abortion is or expresses some form of discrimination against women. Now, what do we do with this? So to me, it is debatable whether this amounts to discrimination, say sex-based discrimination. When I say discrimination, I mean unfair discrimination. I use that as a short because I'm not talking about discrimination in the sense of treating people differently. I'm talking about discrimination in the sense of treating people differently for wrong reason. So it is not the case that any behavior, including withholding healthcare, that results in differential treatment for or outcomes for classes of people, including classes that are identified by protected characteristics, is for this only reason a form of unfair discrimination. So for one thing, conscientious objection is really broader than abortion. So even if it results in discrimination in one specific case, we can't really generalize and make an argument about conscientious objection based on discrimination in the case of abortion. For example, doctors often object to euthanasia, where euthanasia is legal, but that will not be a form of discrimination because men and women are roughly equally likely to request euthanasia. And the second point here is that, as has been established in the literature, and I tend to agree with this point, so conscientious objection is not really discriminatory when the objection is to a procedure and not to a class of people. So the procedure, say abortion, happens to apply mostly or exclusively to a certain class of people is purely incidental. It's not an intrinsic aspect of the objection. So unfair discrimination presupposes that there is the choice of whether or not to apply differential treatment to different groups. If such choice does not exist, then, and if one's behavior can only result in harm to a specific group, then it seems that the behavior cannot be considered discriminatory, as there is nothing to discriminate between. So the behavior must still be wrong or unprofessional, for example, withholding healthcare, but not on ground of unfair discrimination. For instance, in the case of abortion, that choice of discriminating does not exist because if someone has a conscientious objection to abortion, the only group that can be affected is women because only women can get pregnant and request abortion. So the point of conscientious objection is that of preserving one's moral integrity, that is protecting one's own conscience. But if we do accept that conscientious objection to abortion is not a form of discrimination, that might explain why it is accepted as a limit to professional obligations, while things like denying healthcare to HIV-positive patients is not, because that would be a form of discrimination. But even that is problematic because the same thing that I've just said about conscientious objection to abortion can be said about refusing to treat HIV-positive patients. If HIV is more prevalent among gay men, as it used to be, probably not anymore, but as it used to be, then the fact that the refusal of care is more likely to affect gay men is not by itself a form of discrimination. That's just how the world goes. Again, it might be still wrong and an infringement of a duty of care to deny healthcare to HIV-positive patients, but not on grounds of discrimination. So the point I want to make here really is simply that using discrimination as a criterion for setting boundaries to professional obligations does not allow to differentiate between limits to a duty of care on the basis of risks of disease and limits to a duty of care on the basis of reasons of conscience. Now, the second criterion that I mentioned before to try to differentiate two kinds of cost, that is that healthcare professionals should not deny what is appropriate care, does not seem to help either in in understanding why cost of conscience and cost in terms of risk for health are treated differently. What counts as appropriate healthcare is up for debate. What counts as appropriate is an ethical and not a medical issue. For example, one might think that appropriate healthcare is the one that benefits the patients while minimizing harms, or the one that is in the patient's best interest, to use the word that is commonly used these days. This is an ethical decision about what matters in healthcare delivery, what healthcare professionals ought to pursue. But this criterion would be too broad, of course, because not everything that is in patient best interest and that a healthcare professional is qualified to provide ought to be provided. For instance, there are ethical constraints posed by fair allocation of scarce healthcare resources. But if we start adding ethical considerations to what counts as appropriate, we are narrowing down the concept in a way that inevitably leads to disagreement as we keep adding qualifications. And this might include issues around the morality of specific practices, such as the morality of abortion, and the ethics of requesting healthcare professionals to do something that is very demanding for them, either in terms of risk for their health or in terms of infringement of their conscience. Now, while most people would agree that only appropriate healthcare should be provided by healthcare professionals, many will disagree about what counts as appropriate. And this also applies to the case of HIV-positive patients, by the way. Whether caring for them is appropriate depends on ethical issues around the legitimate level of risks that healthcare professionals should be expected to take on themselves. When HIV first appeared, the answer to this question was less obvious and more open to disagreement than it probably is now. So the obligation to provide appropriate care as a criterion is question-begging, because we need to define what counts as appropriate. Now, defender of conscientious objection would deny that certain procedures, such as abortion, fall within the legitimate scope of healthcare. So they would deny that abortion is appropriate healthcare. And I put a paper here as an example of this kind of position. And would therefore claim that professionals should have the freedom of conscience to object to providing, for example, abortion. And those opposing conscientious objection would argue otherwise, of course. Now, it's never been too clear to me why defenders of conscientious objection in healthcare would need to argue that abortion is not healthcare. I'm using abortion as an example, but you may apply the same to other problematic procedure. So what does appropriate healthcare have to do with professionals' conscience? So there are two reasons why the issue of whether abortion is appropriate healthcare and the issue of a right to conscientious objection are independent of one another. So first, if you think that your freedom of conscience should be protected because of the importance of your own conscience for you and the importance of a principle of freedom, then you should be prepared to defend the principle even when it results in the refusal to provide what is considered appropriate healthcare. The value and the weight of freedom is a different type of considerations from the values and principles that define what counts as appropriate healthcare. We can have a discussion about what counts as appropriate healthcare, but that will not be a discussion about freedom of conscience. In fact, legislations and professional codes of practice aim at protecting freedom of conscience precisely because they do allow the practices for which they permit conscientious objection. So they do consider abortion, for example, appropriate healthcare. Indeed, they often require objectors to guarantee that the system provides the service, particularly through the requirement of effective referral. The second reason why whether abortion is appropriate healthcare and whether there is a right to conscientious objection to abortion are independent is that what counts as appropriate healthcare is a decision of the profession as a collective or of the society which bestow on the professionals monopoly rights. Now, there can be disagreement about what should be involved in this discussion, who should be involved, who gets to decide in the end, but it seems strange to assume that it should be up to a professional's own conscience. If your own conscience were to be the final arbiter of what counts as appropriate healthcare, that would result in a very subjectivist approach to healthcare that will be impossible to regulate, given that different people, including different healthcare professionals, would have different views about what counts as appropriate. So responsibilities are established via social contract with society, as expressed either in legislation or in professional codes of practice, or by some shared standard of medical ethics. And again, there is disagreement about which criterion should prevail. In the case of HIV, for instance, the professional consensus is that providing medical care to infected patients is a professional responsibility of each individual healthcare professionals, because the risk of infection is not considered by the profession significant enough to exempt from professional duties of care. According to Rosamund Rhodes, again, each individual physician should be willing to provide treatment for people who are living with HIV because, according to the judgment of the profession, the risk of infection is not significant enough to defeat the professional duty to provide treatment. Now, one might say the same could be said about appropriate healthcare when it comes to the ethics of different procedures and when it comes to deciding what counts as appropriate. is the judgment of the profession. Now, I understand that it would be difficult and inconsistent for you to accept that abortion is appropriate healthcare because someone else, like the profession or society or the legislator, made a decision that you don't agree with, and at the same time to morally oppose it as a matter of conscience. Indeed, the reason you conscientiously object to abortion is precisely because you think it's not appropriate healthcare, given its moral dimension. But that doesn't mean that your conscience should be the decisive factor in determining what counts as appropriate healthcare. What counts as appropriate healthcare might well need to include considerations about the morality of abortion, for example. But again, it is hard to argue that it is up to your conscience to decide such issue in a professional context. I think that whether abortion is appropriate healthcare is an important issue, and I think it should be debated more often and more openly than it's been done these days, especially in this current period. Maybe abortion is not appropriate healthcare, I don't know. But if so, the solution will be not to allow abortion and at the same time allowing freedom of conscience for healthcare professionals. If abortion is not healthcare, that will be an argument against legalizing abortion or against including abortion among the practices endorsed by professional organizations. So proponents of conscientious objection should instead campaign to change the norms if they want, and in the extreme, that might require civil disobedience, which, however, implies challenging the law, even at personal cost, not claiming legal protection from one law or from one professional standard. So if you think abortion is not appropriate healthcare, then the law should be changed, but conscientious objection is just a way of claiming legal protection. It's not a way of challenging the status quo. So it seems to me that within a context where risks for one's health and burdens are the factors that are used to determine the scope of additional obligations of healthcare professionals, a more promising way of arguing for conscientious objection is by framing it in terms of risks and burdens rather than in terms of freedom or moral integrity or what counts as appropriate healthcare. This is because it's already widely accepted that there is a limit to what healthcare professionals sign up to and should reasonably be expected to be signing up in terms of their own health and well-being. So maybe the same is true for those experiences harms related to violation of their own conscience. Now, the issue of additional risks is often discussed both in academic literature and in professional codes of ethics with reference to emergency situations. However, when it comes to non-emergency circumstances, codes of ethics sometimes grant healthcare professionals more freedom to refuse treating patients. For instance, Principle 4 of the American Medical Association Code of Medical Ethics states that a physician shall, in the provision of appropriate care, except in emergencies, be free to choose whom to serve. And this is like a modification on a previous version of the principle that seemed to give more space to societal expectation. But now it seems that this transformation seems to suggest that the American Medical Association moved away from the duty to prioritize societal and patients' interests and put the interests of physicians and healthcare professionals more generally at the center. Now, it is accepted already, after all, that professional obligations do not require healthcare professionals to take on additional risks that are entailed by a pandemic for the sake of caring for patients. It really depends on what kind of risks we are talking about. There must be a limit. So the analogy that is sometimes used is that with a lifeguard who might be required to take on additional risks and burdens, but not, say, the burden of saving a swimmer from a white shark. So the real question really is not so much, 5 minutes, great. The real question here is not so much whether, but to what extent they should incur some additional risks. But there is a widespread agreement that there is some limit to the risks for one's health that healthcare professionals should incur. Now, how far do professional duties go, considering there should be limits? So let's go back to this quote by Rosamund Rhodes that I used before. So to repeat, Rosamund Rhodes says that the profession and its members are required to provide treatment for everyone who needs it and who wants to avail themselves of the service. Now, this cannot be true, of course. So there are so many constraints that will need to be used to qualify this principle. So one obvious constraint here is practical, so there are limited resources, so there are not resources to treat everyone who needs or wants. Another constraint is moral, fairness in the allocation of scarce resources. And another one must be from what we have just said, what exactly a healthcare professional subscribes to when entering the profession. it is hard to believe that a professional signs up either explicitly or implicitly to providing treatment for everyone who needs it and wants it. If there is an outbreak of smallpox, which comes with 1 in 3 chances of death and severe injury for those who survive, which is unlikely but not too unlikely because there might well be a bioterrorism attack, for example, it's hard to say that there is a duty of care on part of healthcare professionals. This seems really too demanding. It would be praiseworthy, heroic maybe, but not a professional duty, because a professional certainly never signed up to that, I presume. Maybe some did, but many didn't. Now, when it comes to the social contract grounded in professionalism, there is a voluntary aspect to the choice of the profession which makes the contract binding. Still, it is impossible to foresee all the situations and risks one might face. Large part of what a professional consents to will still be left implicit. The consent to additional risks and burdens should therefore be based on some shared understanding of what a legitimate expectation is. Besides, it's also unclear what kind of duty to treat is expected as a matter of professional obligations. So this survey of different professional codes revealed that 29 out of 61 codes surveyed had no mention of a duty to treat, and 23 had broad statements. So it's worth noting that traditionally, so as a quote here, epidemics have not been met with the expectation that all doctors serve equally, but with the financing of special doctors or with the exploitation of existing pools of military medical personnel who are habituated to following orders and accepting risks. Now, my question here is, can moral injury caused by prolonged stress of conscience be used to justify a limit of a duty of care in the same way? When it comes to moral injury, it seems that the issue is no longer about fear or risk for one's physical health, like in the case of infectious disease, but it's still about health and well-being in the same way as it was when it comes to severe infectious disease. So moral injury is something that's starting being discussed as a pathological category. So I had a look, I'm really not an expert about this, so I had a look at some of the recent literature about this. And it seems to me that there is this tendency of discussing moral injury as a kind of health hazard or a kind of pathological category. So this paper that came out a few days ago actually talked about moral injury in the military context as the aggravation of the moral emotions, guilt, remorse, shame, to the point of personal dysfunction. So if this is what moral injury does, then there seems to be reasons to equate moral injury to other kinds of health risks and hazards that are part of the profession and that can be used to set boundaries to professional obligations. But I'm sure that Farr and David will have more to say about these categories. Now, to conclude, I have 2 minutes. Perfect. So, final slide, basically. So, we have seen there are 3 candidates for justifying a constraint on a duty of care on healthcare professionals: freedom of conscience, what counts as appropriate healthcare, and moral injury. Now, relying on freedom of conscience to defend the right to conscientious objection does not seem to work because the social contract might well bind professionals to act against their conscience. They are free not to enter a profession that entails practices they consider morally unacceptable, and that is where their freedom of conscience can be exercised. But for the reasons mentioned earlier, they are not free to unilaterally and subjectively determine what counts as appropriate healthcare once they are into the profession. So this doesn't seem to work. Appropriate healthcare, as we have seen, is question begging, and in any case is problematic to allow individuals' conscience to determine what is appropriate in a professional context. However, in the same way as risks for one's health and burdens leading to burnout are taken to be valid constraints on a duty of care, so might risks for one's psychological well-being in terms of moral injury. So mental health is normally considered relevant in defining the scope of professional obligations and exemptions. If one wants to claim exemption on the basis of conscience, this seems to me to be the path to pursue. Occupational injuries and stress justify accommodation of exemptions from responsibilities in a way in which a principle of freedom of conscience does not seem to do. So this will not necessarily make conscientious objection permissible. I'm still skeptical that a right to conscientious objection in medicine can be justified. But for all I've said so far, this seems to me the most challenging argument I will need to face if I had to argue against conscientious objection. But the argument will need to be formulated more fully than I've done, that injury, and moral distress are significantly similar to occupational hazard to equally count towards constraining the scope of duty of care. And I think, well, this is my last slide, main conclusion. No need to go through it. Thank you very much. And now I think Far is going to explain why I'm completely wrong about everything. Right? Yes.